At The Nocturnist, we are careful to ensure that all stories comply with healthcare privacy laws. Details may have been changed to ensure patient confidentiality. All views expressed are those of the person speaking and not their employer.
The work of a medical resident really never ends. There's always another task to complete, another box to check. In fact, there's an old saying that goes, the longer you stay, the longer you stay. I'm Emily Silverman, and this is The Nocturnists, stories about what it's like to work in medicine. In this episode, we hear from Milana Pebenito, a family medicine resident who was taking care of a dying patient, but got so bogged down in her to-do list that she lost sight of the big picture. After the story, we talk about helping patients decide how they'd like to die, the pros and cons of the electronic medical record, and how to manage our ever-growing to-do lists. Here is Milana's story.
It felt like waking up underwater to hear my pager go off when I was the on-call intern at night for the family medicine inpatient service last year. It was around 5 a.m. and I called the emergency resident back who had paged me, and she was super nice. She was so nice that I was kind of suspicious that she was going to try to get me to do something that I didn't really want to do or that would be like unreasonable. But what she said was, there's a woman here who is dying, and I don't know how long she has, maybe hours, maybe days, but I think she should come to you, to the family medicine service, because she's DNR, DNI. And when I hear this, I sigh with relief. Something about the DNR, DNI order that if I die, you don't have to try to bring me back to life, permission, it feels like it's letting me off the hook. I might not have to try to fight the inevitably losing battle against oncoming death. And maybe I'll even be invited to sit with my patient, to be with them during that moment, when they're passing, during that precious moment. And I'm a family doctor, and I think about my practice from cradle to grave. To me, death is as important of a milestone in life as birth. And to be able to be with someone during that time and just sit with them and support them and maybe even experience with them what that's like, that's one of the greatest honors that I may ever get to be invited to participate in my career. So I'm excited about this admission. And I wake up my senior, and we go to the chart, and we learn about this woman, I'll call her Gina. She's 83, and she has lung cancer, and she's been sick for the last year. And in all of her notes with her primary care doctor, she's been really clear about her desire to engage minimally with the healthcare system. She didn't want surgery, she didn't want chemotherapy, she didn't want radiation. She wanted to die at home, and she wanted her devoted husband to be by her side. But she'd been looking sick the last few days, and her husband, who'd been caring for her for the last year, decided to call an ambulance. And so she was here with us in the hospital, and he was at home. So we go to the bedside, and I look at her, and she is really pale. She looks sick. She is breathing really fast, and her blood pressure's kind of low, and she opens her eyes, and she answers, but only in one word at a time. And she's one of the sickest people I had ever seen, and I start to panic inside. So my brain does this thing that's automatic, where I start to think of diagnoses and treatments. I'm like, well, her arm is cold and swollen, maybe she has a clot, maybe it flew into her lungs, maybe we could get her a CT scan, and maybe we could treat her and give her medicine to break up the clot and stabilize it, or maybe she has pneumonia. Just because she's DNR, DNI doesn't mean she can't get antibiotics. I mean, we could maybe try to fight this. And then I remember, oh yeah, that's not what she wanted us to do. That's not what's happening here. She's dying, and our job is to support her with that. So I go to call her husband because she wanted him by her side. And I call him and I say, hey, I think your wife is really sick, and it would be good if you could come here now. And he says, well, I need to move my cars for street cleaning, and it's dark out, and so I'll probably be there in like 4 hours. And I was like, I don't know, but I don't think you have 4 hours. I think you should come now if you can. He says, okay, and I go back to the room, and as I'm remembering that my job is not to try to save her from what's happening, I decide that we should order the Comfort Care order set, which is like a thing that you can order in the computer, and it has all of these drugs that you can use to try to treat suffering. But I've never done it before. So I go to the computer and I'm looking for the order set and I can't find it. And so I decide I'm just going to try to order the drugs like one by one, like just try to come up with it on my own. And I start ordering morphine for pain, but I'm ordering it wrong. And so I'm getting pages from pharmacy. I start ordering Ativan for air hunger, and I order it like 15 different times, and all of them are wrong. And pharmacy's paging me, and I'm on the phone, and I'm battling with the computer. And I look up for a second to realize I'm missing it. The people who aren't missing it are the nurses. And one by one, 6 nurses walk into the room, and they surround her, and they each put a hand on her, and they say, it's okay. You don't have to suffer anymore. It's okay. It's okay to let go. Goodbye. And she dies. 10 minutes later, her husband shows up, and we take him to a room and sit down with him and say, we're so sorry, your wife died. And he looks around the room and he says, oh. He doesn't look surprised. He looks sad, but he's really calm. I'm amazed by how calm he is, and I realize that I was kind of resenting him for not being there, that I was like disappointed that he hadn't made it there in time. And looking back on it, I think like I was resenting him because him being there had become this task that I was trying to accomplish. I had like put it on my to-do list, and I hadn't been able to do it. But I still had a lot of other to-dos that I definitely could do. Like I had the death packet, and I had to call the coroner, and I needed to write an admission note, and the day team was coming in like a half an hour. So I get in the elevator, and I go up with my senior, and she turns to me, and she has tears in her eyes, and she says, can we talk about that? That was really intense. It's a big deal. And I'm like, no, I don't want to talk about it. We have so much stuff to do. We don't have time to talk about it. How are we going to do all of our stuff if we talk about that right now? And so we don't talk about it. And when I look back on that day, I realized that I had started to put that task list, that list of to-dos, in front of the people that it was generated to serve. So I'm working on being better at that.
So I am sitting here with Milana Pebenito. Milana, thank you so much for joining me.
You're welcome. It's my pleasure to be here.
Yeah. I am so excited to talk to you about the story that you told at our event on the theme of death and dying in October 2016. And your story resonated with me especially because I feel like it really painted the experience of what it's like to be not just a doctor, but to be a resident doctor, to be a doctor in training. And so we'll get into that a little bit in this interview. But before we do, I like to ask people to tell me at the beginning a little bit about their path to medicine.
My path to medicine was not very intentional.
I thought that I was going to be an educator, and so I became a high school teacher, and I taught high school for a couple years, and I got really exhausted and felt like I wasn't able to address my students' immediate needs. But I realized that I liked talking to them about their bodies. And I remembered that someone had said I could think about going into medicine. And so I applied to medical school. I did not know what I was getting into.
That sense of ineffectiveness that you describe in school, I imagine, resurged a little bit in the practice of medicine, but I don't mean to project too much.
That's true, actually. I feel somewhat ineffective a lot of the time, but I think that something about feeling humble to the miracle of the human body and knowing that I don't have to be in control of everything that happens to people's bodies, that's a little bit easier for me.
That makes sense. It's the natural order of things that people will get sick and die, but not necessarily the natural order of things that students will be reading behind grade level or something like that.
Exactly.
At the very beginning of your story, you talk about getting a call, I think from the emergency room, that it's time to admit a patient and the patient is dying. And then they say to you, the patient is DNR, DNI, and you describe this wave of relief that washes over you. Can you explain to any listeners who might not know what it means to be DNR, DNI, what that means? And then why do you think so many residents, I think this is a pretty common feeling, feel so relieved when they see that status tagged to their patient?
Yeah, so DNR, DNI means do not resuscitate, do not intubate, which is kind of like saying don't try to be a hero in the face of something you can't change most of the time. Sometimes people die and miraculously you can bring them back to life. Most of the time people die or are dying and you can't really change what's happening, but you still try, and you try really hard, and you can try really long, and you can even sometimes bring organs back to life, but most of the time you can't bring people back to life. And it's a traumatizing effort for all of us in medicine to try to bring someone back from the dead, or to try to stop this train that's on its way to a destination that it needs to go to eventually. And so I think that in that moment when I was hearing from the emergency room provider who wanted to admit this patient to me, that I didn't have to try to stop that train for this particular patient. Without even really knowing her, I felt relieved for myself that I didn't have to go through that process of trying to be a hero in a way that I knew I could never actually be.
And how can that be traumatizing for the medical team?
Yeah, I think the thing that feels the most perverse to me about it is that it's really a missed opportunity to support a person through a life transition. I think of the greatest privilege of medicine is being able to support people through these the most incredible moments of their lives. Sometimes the happiest moments when babies are born, and often some of the saddest and scariest moments when they have a new illness or when they learn that they're going to die, and ultimately for everyone, when we do die, we will hopefully be supported by a physician. And when someone is at the end of their life and is dying, to try to fight their death feels like I'm missing that opportunity to really help them through that by fighting it. If they're still conscious. A lot of the time they're not still conscious. And then it feels like we're trying so hard to do something that we just can't do. And it feels like we do it because we haven't agreed as a society that death is okay. And that feels very frustrating. It feels like a great loss.
Can you talk a little bit more about society's idea that death isn't okay?
Yeah, I think that I'm not sure where it comes from, but I think in general in the U.S. we have this expectation that that we should fight death at every turn. That somehow being okay with life ending would be to give up or to be weak, or to be ungrateful in some way, to not appreciate life enough. I wish I understood the history of that sentiment. It's kind of bizarre when you zoom out and think about it, because it's been happening since there were humans, and somehow we haven't figured out how to say, this is something that happens. And
it's natural.
Yeah. Let's come up with a way to deal with it that feels good.
So next in the story, you talk about ordering the comfort care order set. Can you tell the audience, what is the comfort care order set?
The comfort care order set is a set of orders for the nursing staff that give instructions on how to pay attention to a patient's level of suffering. Nurses are always paying attention to patients' suffering, but it asks them to focus sort of first on their comfort and suffering and less on their vitals. So less on the things that might tell us someone is about to die and you might be able to do something to stop it from happening, and more on the things that tell us this person who is dying is comfortable or not, and gives them medicines to give the patient to help them be comfortable during that time. So medicines to take pain away, medicines to take anxiety away, medicines to take away air hunger.
I'm glad that you mentioned nurses, because another part of your story is you're battling with the computer and you're fielding pages from pharmacy, and you look up and you notice that it's the nurses who aren't missing it. They're already gathered around the patient. What do you think it is about the nurse's role versus the doctor's role that makes it so much easier for the nurses to be tuned in to what's happening in real time, and so much easier for the doctor to be bogged down in the checklists?
You know, in my dreams, this is a problem that is unique to residency and my training that I will eventually graduate from and will not be so bogged down by the checklists and the computer. But probably in reality, I will always be a step further away from the patient than the nurses. Sometimes in the hospital, it feels like the nurses are my five senses, like they're my eyes and my ears and my hands. There are moments when nurses call me and say, oh, the patient's blood pressure is this. And I ask them, oh, how are they feeling? What do they look like right now? Because I'm not there at the bedside.
Right.
And the nurse's job is to be at the bedside as often as possible. And I think that many nurses, friends of mine who are nurses, have told me that they see their role in particular as the patient advocate, which always irks me a little bit because I worry, am I not also the patient advocate? I mean, I want to be the patient advocate, but I think nurses especially see themselves as the go-between between the patient and the physician, and they can really advocate in a unique way for what patients are really experiencing. They spend more time with the patients.
One of the reasons why I loved your story is because it encapsulated ways that the computer and the electronic medical record can hinder care. You talk about how you want to order this comfort care order set, which is really just a handful of medications, and you're battling with the computer and you're getting pages from pharmacy. How do you view the electronic medical record? What are the pros and the cons, and what are some ways that you feel like it helps you or hurts you when you're taking care of patients?
When I was planning to apply to medical school, I remember thinking that the electronic medical record was changing everything and was just the coolest thing, that we were going to be able to collect so much data. As a high school teacher, I thought this was really akin to my grading and keeping track of my students' reading levels and how we were moving forward. I thought about it as this incredible asset to population level healthcare. And I think it still is and still can be that. But in the individual patient interaction, it really feels like a screen at times. From the very beginning of this patient case, the ED doctor had flattered me that she wanted the patient to die on the family medicine service because we would be so great at taking care of her at the end of her life. Because we're a sensitive service, we're a holistic service. We think about patients in the context of their families. And then the moment came and I was at the computer, not really able to sense what was happening in the room because of the task that I thought was in front of me. And that felt really, really sad to me. I felt like I was really missing out on something that seemed really important.
And you were trying to accomplish a task. You were trying to get these medicines ordered, and the orders just weren't going through properly. And so it seems to me, I don't know if you could call that a patient safety issue. I think you probably could, that it was obstructing care. I mean, it really shouldn't be that difficult to order a few medicines, don't you think?
Yeah, I dream that someday the computer and ordering medicines will be sort of like Siri. Like I'll be able to just say, give this patient Ativan right now. And the computer will already know the appropriate dose and frequency, and that has its own safety risks. But ultimately, I wish that I could have a tool that would allow me to take care of my patients in a way that doesn't make me take my eyes off of them. And I know that patients wish for that too.
Yeah. So I want to transition to talking a little bit about this patient's husband, because he featured in the story a little bit. It sounds like he knew his wife was dying and he, for whatever reason, didn't feel able to be there to witness that. And one of the tasks on your to-do list was call patient's husband, patient wants husband. Can you talk a little bit about the to-do list and what that means for an intern or a resident and how that can kind of drive your workflow?
Yeah, I think especially as an intern, I felt like the checklist and my ability to accomplish all the tasks on the list was a reflection of my aptitude and efficacy as a physician. And even something that is so outside of my control, like getting another human being to come into the room to be with his partner during her death, that felt like equally one of my tasks, something I was responsible for accomplishing, as getting the comfort care orders ordered and getting the patient to out of the emergency room so that she didn't have to die in the emergency room, and also considering any of those measures that I could have possibly done that maybe would have been within her goals of care, that I know now wouldn't have changed anything, but at the time I thought maybe could have. And when I called this patient's husband, he said that he couldn't come because he needed to move his cars in the morning for street cleaning. And I didn't really think in the moment much about that statement other than that he's saying no. I think he doesn't understand what I'm telling him. I need to be more clear so that this conversation can end and I can get to the next task. Right. And he will be here and I will have done that thing that I said I needed to do. Looking back on it, I realized that it's possible that he couldn't bring himself to be there. And if I had known him better, I may have been able to talk to him about this. Potentially I'm projecting onto him, but my experience with other family members has taught me that sometimes what the patient wants at the end of their life is not what other family members want for themselves at the end of that person's life. This patient had said she wanted to die at home, and her partner had called an ambulance and had her brought to the hospital. Right. And we informed him that we thought she was dying and that we thought he should come to be with her during her last moments. And he said, I can't come right now. And he came. He ended up coming after she died. And I think that after all of this, I had some time to think about, what maybe was he feeling. And it occurred to me that maybe his partner dying in their home that they had shared for decades was too hard for him.
Right.
And I really, really empathize with that feeling. And at the time, in the moment when I was talking to him, I wasn't able to consider that as a possibility. I just saw him getting there as my job to accomplish. Right. And now when I think about it, I realize, it doesn't have to be my job to get someone to do something that he doesn't want to do. And it's okay that he wasn't there.
Right. There's definitely this trend, I think, toward perfectionism and wanting and feeling like you should be able to accomplish everything you want to accomplish in a day. And often that work is tremendous and it's a treadmill. It never ends. And being able to set boundaries and decide that today the day is ending and whatever I didn't accomplish, as long as it's not an emergency, it can wait till tomorrow. This patient dies and you get in the elevator with your senior resident, I think, and you're looking at your to-do list and she turns to you and she says, that was really intense. Do you want to stop and talk about that? And there's so much on your mind with the to-do list that you actually say no and you just continue with the work. Obviously, there's a lot of intense things happening in the hospital all the time, and it's not feasible to debrief about every single one because then you would never get your work done. But at the same time, if you never debrief, then it just feels like you're not tapped into your own sense of humanity. What do you think about this and how do you wrap your head around this?
I think it is so hard. I think that most of us develop the skill that we call compartmentalizing, where we take all of our feelings, we put them into a little box, and we sometimes let them out in private places. We save them for later, sometimes days later.
Or weeks later.
Or months later. And
sometimes the box opens up without you giving it permission.
Yeah.
Just at random times, it'll hit you.
Yeah. And I think that the expectation we all have for ourselves is that we're in control of the box. The box doesn't get to control itself. It's not supposed to open on its own.
Right.
And I really lament that part of the culture of medicine. But I think it's something that we learn to do so that we can keep going. And I wonder if our patients expect us to do that. Sometimes I think that that our patients do expect us to do that. And I think that's dangerous because if I believe that, then I will keep doing it. And it's probably not safe or healthy for me because it's an everyday process, an everyday burden to tuck away your feelings and to not be able to deal with them in the moment.
Well, I don't think there are any great answers to these questions, but they're sure important to talk about, and I'm glad that we did. And it's been such a pleasure to chat with you about these complicated topics, and thanks again so much for coming.
Thank you for having me.
That was Milana Pebenito. Thanks for listening to The Nocturnists. If you like the show, please share the Nocturnist podcast with your friends and colleagues and leave us a rating or a review on iTunes. We really want to hear your thoughts and feedback. I'd like to thank executive producer Allie Block, podcast producer Marina Poole, Celine Ross, Kirk Clockey, Stephanie Muscat, and our music is from Yosef Monroe and Blue Dot Sessions. See you next time.